Will you be able to remember? Did you even register how many shots were fired? No. So similarly, all we see in an echo at the same time, we may not be able to register everything. That's the limitation. Now, many data that we need in echo is time consuming to gather, difficult to manage time in a busy lab. Now, you remember in late 1990s, there was a survey which was published in the newsletter of British Society of Echocardiography. It was published by Graham Leach. Some of you may know him. Now, in that survey, it showed that the average time for an echocardiography in the UK at that time was 24 minutes. And it hasn't changed much since then. You know what's the average time for echo in our lab? Guess? It's just 4 minutes. And this is just to show that we are more efficient than the British. Then again, echo, especially because of its workload, adds musculoskeletal stress on the operator, apart from mental stress. So these are many of the limitations. But how could AI help? It can help in automatization of tasks. Example, in determination of LV volume, mass, ejection fraction. It can save time. It can help in discovery of clinically important insights that human eyes may miss. And it can help in incorporation and analysis of echocardiographic and clinical data, which may help in diagnosis, determine prognosis, and help in decision making. Now, before we incorporate AI in our daily practice, we need to answer two questions. Is the AI-generated data useful? And is the AI-generated data accurate? So let us see what are the areas where AI could help echocardiography and whether they are accurate and useful. Firstly, about assessment of LV function, ejection fraction and longitudinal strain. Now the EchoNet RCT was designed to test whether AI-generated assessment of cardiac function was at least as good as that of a sonographer. So all these echoes were divided into two groups. In one arm, those who were actually assessed by the sonographer, and the other arm, which had AI assessment. And the results were blinded to an experienced cardiologist who didn't know which arm the report belonged. And it was found that the cardiologist agreed more often with the AI-generated data rather than the sonographer interpretation. And actually, statistically, it was shown that AI-generated data was superior to that of a sonographer. If you look at the FAST-EF multi-center study, it showed that AI-generated measures of LV function like EF and longitudinal strain were reproducible and could be done very rapidly. Coming to LV volume measurement, well, again, machine learning helped you to obtain the dynamic quantities of LV volumes more quickly and more accurately. And similar thing was true for LV mass measurement. Now, what about assessment of wall motion abnormalities? Now, it showed that the AI could prove improved detection of regional wall motion abnormalities, which was better than the human eye could perform. And another study showed that for detection of wall motion abnormality, AI has a sensitivity, specificity, and accuracy of 96%. And if you incorporate AI in stress echo, then you can better categorize a group of patients who are at a low risk of imminent cardiac event. What about assessment of LV diastolic function? Now, in patients with suspected elevated LV EDP, echocardiography, AI was able to identify correctly about 80% of patients with pulmonary capillary wedge pressure more than 18, even from a 2D cardiac ultrasound image. And it was also seen that from a single apical 4-chamber transthoracic echocardiographic video clip, AI is able to discriminate patients very well, those with heart failure with preserved ejection fraction and those without heart failure with preserved ejection fraction. And if you compare the conventional scores that are used to diagnose patients with heart failure with preserved ejection fraction, AI did better in the sense that they are able to narrow down those those patients who would otherwise be non-diagnostic with the heart failure scores. Now, coming to assessment of valve disease. Now, we have learned about mitral valve regurgitation, MR, for example, but how many of you do you really get time in a busy lab to do all these things? Now, most labs, they don't. Forget about probably a few labs which are really good and doing it all the time, but most labs, they do not. They do not have the time, and probably they may not be that trained as well. So this comes to say, for example, measurement of PISA. It's time consuming. How many do it manually? But with AI, you can generate all the data in few seconds. So it's really helpful. Not only that, look at the valve morphology. There are other things that you probably may need. What about the mitral valve area? What about the coaptation length, coaptation depth that we talked about? All these things can be provided with AI. And similarly, AI can, in patients who are going for TAVI, AI can give us a measure of the aortic annulus, the size of the aortic root, and may help us to choose the TAVR prosthetic size. Now, coming to RV volume and function, yes, AI can also give an accurate quantification of RV volume and function. It may also help in differentiating among disease entities, such as to differentiate from constrictive pericarditis and restrictive cardiomyopathy.